Historical aneurysm practice has been predicated on the established size threshold for repair of 5.5 centimeters. In fact, this notion remains endorsed currently by both the SVS and European societies, giving it a Class 1A recommendation. Yet closer scrutiny will reveal that this recommendation remains based on trial data demonstrating no benefit of repairing aneurysms smaller than this size. As nicely stated in this European Journal editorial by Earnshaw and colleagues, the diameter of 5.5 became the agreed-upon indication for elective intervention based on a potential misunderstanding of the cumulative evidence. In this setting, the SVS has since modified its guidelines, decreasing size-associated AAA rupture rates, making the current optimal size threshold for repair less certain. We therefore sought to better characterize the optimal size for AAA repair in current practice. To accomplish this, we performed a Markov chain model to estimate life expectancy for aneurysm patients using hypothetical base cases in both men and women. The primary endpoint was AAA-related mortality. We derived life expectancy from the Social Security Administration, annual rupture risk from the SVS estimates, and postoperative mortality and complications using VQI. What we had determined is shown here. On the y-axis is survival, and on the x-axis are repair size thresholds for a 60-year-old woman in average health. As indicated by the line, the optimal observed repair threshold was unexpectedly 6.1 centimeters. Furthermore, life expectancy varied by less than 2 months for thresholds between 5.7 and 7.1 centimeters. Likewise, shown here is the respective model for a 60-year-old man in average health, where the optimal observed size threshold for repair was 6.9 centimeters. And again, shown in this slide, the range over which life expectancy varied by less than 2 months was 6.2 to 8 centimeters. This figure is a forest plot demonstrating the optimal size threshold and associated ranges for different base cases. On the left, you'll note the base case, and on the x-axis is the repair size. Please notice that the optimal size threshold, not surprisingly, increased in parallel with advancing age and was even higher for those in poor health, with most in excess of 7 centimeters. Likewise, shown here among men, all of the thresholds to minimize AAA-related mortality were higher than 5.5 among average health men and in excess of 8 for poor health men. This table shows the results of our sub-analysis, which demonstrates the risk of all-cause mortality for 60-year-old women with a 5-centimeter AAA. And shown here was our sub-analysis for women and all-cause mortality at different repair size thresholds. You'll note that there is no inflection point in the curve indicating that there was no size threshold at which patients should be repaired to reduce all-cause mortality. This work has important limitations which are important to note. Perhaps most importantly, we must recognize that women may have different AAA rupture and expansion rates, which are less certain given their underrepresentation in prior important trials. Also, optimal size thresholds are different when assessing AAA mortality and all-cause mortality. Nevertheless, all sizes in men and women that we modeled were larger than current recommendations and historical size thresholds for repair. To conclude, it is possible we are repairing more AAAs than necessary to minimize the risk of AAA-related mortality. We should accordingly revisit the optimal AAA repair threshold in both men and women. This may prove to be a more nuanced approach than the current one-size-fits-all approach. Thank you.